It's good afternoon, everyone. Thank you for joining us today. For those of you who may not have had the pleasure, or I haven't yet had the pleasure of meeting, whether it's on Zoom or otherwise, my name is Brenda Verkleon, and I am the collaborative co-lead of the McMaster Collaborative for Health and Aging, alongside Dr. Rebecca Ganand, who unfortunately we just learned is not able to join us this afternoon. But this is being recorded, which is good because we can always catch up. And I'm just so excited that we're hosting our last collaborative conversation of the calendar year. I guess it's not calendar year, academic year, right? It's June. While we are gathering today on Zoom, I'd like to begin by acknowledging that the land on which McMaster is built and where I am signed in from today are the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. We acknowledge the importance of the land, which we each call home, in part to reaffirm our commitment and responsibility to improve relationships between nations and to improve our understanding of local Indigenous peoples and their cultures. I take this moment and invite you as well to join me to remind ourselves of our commitment to equity and fairness in our work and beyond. And improving fairness includes acknowledging and addressing structural barriers and inequities which continue to exist in part due to the colonial history in Canada. I'd like to welcome all of you, including our presenters and members of our Collaborative Leadership Council, Dr. Kathryn Fisher, Dr. Melissa Northwood from the School of Nursing at McMaster. And we're joined by some of their community partners, Ethel from the Scarborough Health Network, and their patient research partner, Frank Tang. And they'll introduce themselves in a moment. And we have so many others on the line, those from family health teams, Diabetes Action Canada, our partners from the McMaster Institute for Research on Aging here at our university. And again, the people leading the charge here will be introducing themselves in a few minutes. You can also read more about the collaborative from our website, and as you know, learn more about today's event and the description of today's event on our website. So in this series, we do bring together researchers and people with lived experience to share their journeys and lessons learned in patient-oriented research done in partnership with individuals and communities. So before we get started, I do have some of those lovely housekeeping items. We already heard sometimes our microphones come on, so keep an eye on it. And I'm trying to remind myself right now. So we want to make sure, right, that the people whose microphones should be on are on so that we can share. We will, like, in case you start talking and forget to turn your microphone off, we're keeping an eye on things too. So we'll gently remind you to turn your microphone on in case you forget to do that in this lovely Zoom forum. We are recording this event and it will be shared and posted with some of our past conversations on our website. You can disable your video again if you don't want to be recorded on camera, and we will stop recording before our reflecting together time that begins at 1 p.m. Questions and conversation are welcome and encouraged at the end of the formal presentation, but please feel free to use the chat function throughout today's conversation. There is a live transcription and closed captioning option with Zoom, and it's been enabled, and it can be turned on or off by you individually using those 3 dots. They always lead to good things, and that's the more button in Zoom. So lastly, you're invited to join. You heard me use the term reflecting together, and that's an opportunity for all of us as trainees, collaborative partners, and community members to come together and share your thoughts on the topics discussed. And that takes place from 1 to 1:30 p.m. And we're fortunate. I know Sue just reminded me, Mike is here, one of our partners, and I think Tina, right, is here as well to help us support those conversations. So thanks to them for helping us have those conversations. And there are older adult partners as part of our collaborative advisory committee. Yeah, so I just have one more quick slide just to remind you about what our Collaborative for Health and Aging is all about. And we look forward to you following up With us, we are a coalition of researchers, trainees, older adults, and caregivers working together to improve the health and well-being of older Canadians to advance patient-oriented research on aging. And we use the term patient here because that's in part the way things have been framed here in Canada, but we know it's more than sort of the traditional patient when it comes to partnership in these different various capacities and forums. Health is wide-ranging, as we know, beyond sort of the hospital and traditional health context, but the patient perspective is part of that and important. So we aim to achieve our aims, I'm saying aim a lot, but we aim to achieve these. Our objectives is to provide research and engagement consultations and support, promote training and mentorship, and to facilitate partnerships and knowledge translation, which are all fancy words for let's get the information out there. We need the information in here, and we need to all work together to help advance health policy and inclusive aging for everyone in the health sector and beyond. So we look forward to connecting with you through our social media channels. Thanks to Allison and Sue, our communications and staff leads within the collaborative who help make sure that we're up to date and keep everybody up to date on the fantastic initiatives that our various members of the collaborative are doing. So you'll find our past collaborative conversations on YouTube and links there, and our website and all of those things. So yeah, link through to these various initiatives, including the one today. I've already talked about reflecting together, so we will, as I run, to our, but I think that actually this slide might be the very last slide, right, Allison? I think I just lost you for a second here. So let me, without further ado, turn this over to Melissa and Kathy. So I'll stop sharing, and but I hope you'll stay on the line at 1 o'clock. That's the point here, to continue the conversation if you're able to do that. And we look forward to talking about that. So thanks very much.
Thanks, Brenda. This is Kathy, and I'm gonna start things off here, and then turn the presentation over to Melissa. So I'm going to begin with a little bit about the research project and the intervention and situating it within that research project. But before I do that, just wanted to acknowledge a shout out here to our research team, which was lots and lots of people helped along the way here. So Maureen Marco Reed was the NPI, and Jenny Plow, both of whom have retired, but Melissa and I are still here representing the team. But there's lots of folks here, other researchers from various universities, patient partners, policymakers, and we're spanning 4 provinces here. So we've got PEI, Quebec, Ontario, and Alberta represented here, and a big team. So yeah, and then also, in addition, we collaborated with a number of partners along the way here. So again, representing the policy arena. So we've got provincial health ministries, we've got LIMS in here, for example, we've got primary care reps, we've got community partner organizations like the Toronto Central YMCA, for example, and our study sites are represented here. So St. Mike's Hospital and Scarborough Health Network. And then finally, we can't forget our funders who have helped support this project, and it wouldn't have happened without them. And there were lots here. So Diabetes Action Canada and Scarborough Health Network, CIHR, both the Maureen's chair and the PICI grant itself. Yeah, so Mira, we've got all sorts of support here that made this project possible. What we're going to talk about today, after I introduce the intervention and give you a little bit about that, is focused really on the latter part of this research project, which was scalability assessment and the tools we used to assess scalability, the stakeholder involvement piece in particular, to form that assessment, and some of the challenges that we experienced in trying to assess scalability of the intervention for this research project. So the intervention, this is a bit about that. It's the ACHRU Community Partnership Program, ACHRU-CPP, and it was a 6-month intervention that was delivered by an interprofessional primary care team that was made up of a registered nurse, RN, registered dietitian or nutritionist, RD, and these folks were all trained in as diabetes educators. and then a community program coordinator, which was typically a kinesiologist from our community partner organization. And so that's who delivered the program. And then it consisted of these core components. On the left-hand side, there were 4 key ones. And these components came from looking at best practices, the published research, and working with our providers and patient partners to come up with what the structure of this intervention should be. So the first component was home visits, and up to 3 in-person or virtual visits by an RN or RD were offered to participants in the intervention. And it was virtual or in person because we actually got caught in this trial in the middle of COVID. So some people had received in-person visits, which that was the original intent. And then we switched to virtual when the pandemic arrived. So some people got a blend of both. Some people got in-person only. Some people got virtual only. It was a mix. And then group wellness sessions, there were up to 6 in-person or virtual group wellness sessions offered to participants. And those sessions were focused on health education, physical activity, and peer support. So there was a socialization component to it. And again, there were virtual and in-person there, depending on when they happened. The team-based care was another core component. So the team worked together and actually met monthly to have case conferences where they discussed the participants' care plan and kept all of the providers on the same team. And then finally, care coordination and system navigation. So this was tailored, this was nurse-led, and it was intended to link patients with community-based resources and to collaborate with the primary care teams. So those were the 4 main components. The intent of them was, on the right-hand side, to impact a number of outcomes. So we had something like 9 outcomes in this study that we actually measured and looked for effects of the intervention on. So mental and physical functioning was one, diabetes self-management, increased physical activity. We were trying to reduce nutrition risk and reduce a number of mental health outcomes like depression, depressive symptoms, and anxiety, and then reducing costs of the use of healthcare and social services. So those are some of the outcomes that we measured and intended to impact with this intervention. And now situating that ACHRU-CPP intervention within the program of research. So here's this whole program. It's a busy slide, but try to walk you through this briefly. On the left-hand side, those blue circles or ovals, that was existing research that we had done. So evidence that we had in place. So we started all of this, oh my goodness, I think it would have been back in 2015 or 14, where we were actually meeting with providers and patients or clients with diabetes and getting an understanding of what the intervention should be. We actually piloted it in Guelph and did a feasibility pilot study. And then we actually ran 2 pragmatic trials in Ontario, one in Ontario, one in Alberta. So that gave us some an evidence base for this current research program, which consisted of 3 studies. So study 1 was actually a population-based study using administrative data to try and understand the characteristics of high system users. So what we had from our previous evidence was not a lot of those folks. Sorry, got an alarm going here. That's not very helpful. My apologies. So we wanted to see about some of the more challenging groups that we hadn't looked at or been able to recruit in the past, high system users being one of them. So high needs, we were wanting to see whether the intervention would actually work for those folks that had a higher need. So this study 1 was actually giving us the characteristics of high system users, which we could use to recruit the trial, the randomized controlled trial folks, which is study 2. So this is a trial, pragmatic trial that looked at the CPP to evaluate its effectiveness and implementation in the practice settings. So an RCT, and then that informed stage 3, which was really the scalability assessment. So this part on the right, we had provincial forums where we presented our results and actually engaged a number of policymakers, providers, patients to help us assess the information, synthesize, assess, and actually arrive at a scalability assessment for the CPP. So along the top, you see study 3. So it really is a a synthesis of what we know from studies 1, study 2, our previous evidence that all came together to help us assess the scalability of the CPP. And then now focusing on that study 3, that scalability assessment. The first thing is what we should talk about is what do we actually mean by scalability? And so what we mean by it, or how it's normally defined, is it's the ability of a health intervention shown to work on a smaller scale or under controlled conditions. So an effective health intervention, the ability of that effective health intervention to be expanded to reach a greater proportion of the eligible population, target population, while remaining effective. So that's, we've got Malat here as the source of that. Malat and his team, I think they're out of Australia. They have done a lot of work on scale up, the process, and scalability in developing tools that support scale up. So that definition comes from that group that's been leading the scale up initiative. And in our case, the process, the scalability assessment process, had these 5 components to it. So we began by forming provincial working groups, and we had 2, one in Ontario, one in PEI. So we could, even though we had three provinces, Quebec was the 3rd, we couldn't, we didn't involve them in these provincial working groups because they had to stop the trial. Due to COVID and people being redeployed, the intervention couldn't continue, so the trial stopped. But in Ontario and PEI, they followed through, were able to follow through, and we had working groups that were members of steering committees, patient partners, our research team, and primary care and community folks. So they were part of a working group that guided the scalability assessment. We did a document analysis and environmental scan. That's where we went out to search for what's going on policy-wise, what are the initiatives, what are the priorities in the provinces, what community-based resources are actually out there that would support the intervention, and so on. So we did that as part of this exercise. We interviewed key informants. These were folks from the health ministries and healthcare leadership positions in both provinces, and asked them about scalability of the CPP. Then we held scalability assessment workshops virtually in December 2022, and we had one in Ontario and one in PEI. And participants actually rated the scalability of the CPP and also gave us some understanding of barriers and facilitators they could foresee if we were to scale up in the provinces, scale up the CPP in the provinces. And then finally, we wrote all of that up in a formal report that we shared then with participants from the workshops and policy and decision makers. And then a little bit of insight into the tool we used. So it's called the ISAT, Intervention Scalability Assessment Tool. Again, it was developed by Malat, that team from Australia. And why we chose this, there's a number of different ones, but why we chose this tool is that because it was designed for high and middle income country interventions, the implementation and assessing the scalability of them, which is what made it a little bit unique, and it's much more applicable. A lot of the scalability assessment tools, other ones that are out there, are for low income countries and very different interventions. So this tool seemed to apply better to our situation. And the use of a tool generally is really just so you can systematically assess the scale up or the scalability of an intervention. And the tool we used, it consists of 2 parts, part A and part B, and 10 domains. So part A on the left is really focused on what's the problem, what's the healthcare problem, what's the intervention, so the CPP, and how is it addressing that problem. The political context, meaning the initiatives and priorities that exist in the province and how the intervention fits with those, the political context. And then what evidence do we have of effectiveness? So the results from prior work and this current RCT that we ran as part of the program of research. What does that evidence tell us about the effectiveness for various outcomes, and looking at costs and benefits as well? So that's part A, assessing the intervention on those domains. And then part B, the right-hand side, is looking at more implementation of the intervention. So fidelity, meaning how easy was it for providers to deliver the intervention as we intended it to be delivered? How did they have to adapt it for the environment, reach and acceptability both from providers and patients of the intervention, delivery setting, the workforce requirements, the implementation infrastructure, what do we need to actually deliver the intervention out there in the practice setting, and then sustainability, how likely is it that we can keep this intervention going, and what do we need to do to ensure its longevity. So I think it's time to turn it over to Melissa to tell us about the results of the ISAT.
Thank you, Kathy. Happy to do that. And this was about the time that I joined the project when we moved into this final phase, the scalability assessment. So I'm really pleased to be here today to share some of our results. So this is a radar plot, and we're just showing you the assessment that was done in Ontario, just to give you a sense, but we'll talk about both of the provinces. So as Kathy said, in our virtual workshop, people rated the readiness for scalability of the community partnership program, again on that scale from 0 to 3, with the higher scores showing a higher degree of readiness. So you can see here that the potential scalability was rated quite high, between 2 and 3 on average for each domain, and this was true in Prince Edward Island as well. So in both of the provinces, participants identified diabetes among older adults with multiple chronic conditions as a really significant problem that would warrant the scale up of this program. So that's domain A1 there, the problem. People agreed that the key components of the intervention were reasonable and that they would meet the needs of older adults living with diabetes. So that's domain A2 there, the program. They rated the evidence of effectiveness relatively lowest across all the domains. In that trial, there was no statistically significant differences between the groups. So the people receiving this diabetes program fared as well as people receiving usual care. Although the participants acknowledged the impact of the pandemic on the trial, it was designed to be an in-person program, and it had to become a mix and then become all virtual. So that certainly affected the outcomes. And they thought maybe we should be looking at different outcomes, measure different outcomes for this program. Maybe we missed the mark there. And they also thought that perhaps some of them, there was different groups of older adults who may benefit more from the program. So in Ontario, participants suggested that we target racialized older adults. And then in PEI, they thought maybe we should look at people that are high users of the healthcare system. Maybe this program would be right for them. So that's kind of reflected in the rating around B2, kind of at the bottom to the side. In PEI, they agreed the program could be integrated into primary care. But in Ontario, there were some concerns raised about whether the designated funding would be challenging to obtain. So that's reflected in B3 in their rating of the delivery setting and workforce. So these are a snapshot of our key learnings from the scalability assessment, that phase of the research. Context really matters, and it was very important for us to assess the readiness to scale up in local contexts. Given the differences we saw in recommendations between the provinces and even at the regional city level when we were talking with our partners in Toronto. It was critical that we had diverse perspectives at the table. And while there was a lot of consensus, certainly policymakers, our health and community care leaders and patient partners all brought very different ideas to the table. And tensions will arise, which is good and exciting. And we had to really balance the different types of evidence in thinking about our next steps. So a lot of our community partners and patient partners had a lot of enthusiasm for identifying a target group that would benefit most from the program. And then as researchers, we were thinking, oh no, but we don't know who that is yet. We haven't figured that out. So it was taking a kind of balanced approach to the assessment. So these are our next steps. We want to work with our partners on identifying that priority population who would benefit the most from this program, and then start a small scale up with those populations in a phased kind of horizontal approach as the scalability language, rather than launching it across the province all at once, for example. We're going to hopefully start scale up at sites where we can leverage the existing infrastructure in our partnerships and expertise, which Ethel and Frank will build on during our conversation. And then we'll continue to gather more evidence on what works in the program and what we can do to make it better. So on that note, I am going to stop sharing my screen so we can enter into conversation, our fireside chat, although let's not do a fireside chat today, with Frank Tang and Ethel Macatangay. And I think I'm turning it over to Kathy to get the
ball rolling on the fireside chat and without the fire. So maybe we'll start with a question for Frank, and asking Frank about his role in the project, and why, more generally, is it important for patients to be involved in research projects like this?
Well, thank you very much, Kathryn. I think the question was, what was my role on the project? I've been a patient partner for over 4 years, so going on 5 with ACHRU. And I think it's very important for a patient to be involved in the research, because it lends a voice and credibility of people with lived-in experience, rather than just researchers that work in the academia environment. It's important that when you here, in my particular case here, Kathryn, I have type 2 diabetes, and I was a caregiver for my mother, who was also had type 2 diabetes, and the challenges that she went through the system right now, and like my mom, English was not her first language, and especially when she went to see the specialist, it was a challenge. So trying to get people that could translate the doctor's diagnosis to her and what the care and attention she requires. And I found out that it wasn't just her, but generally people that are, I think, from the minority cohorts, they need a lot more of this understanding, because diabetes, especially in the Asian community, is always considered as a stigma, and it's not something that you talk about outside the family. And trying to get their confidence in understanding why are we here trying to find out more is always a barrier. And I think it's extremely important, Kathryn, if I could use you as a focal point, is that how can we sort of break that barrier and get more people that are involved, that have diabetes, to speak their minds out, because that is extremely important. And that's the reason why I'm so involved in it. A, from the standpoint of for myself to learn more about what is being done, and B, number 2 is that how can I contribute to the overall process? So I'll stop there here, Kathryn.
You know what's interesting, Frank, is what you just said. I have a friend, close friend, and she has type 2 diabetes, just diagnosed, and the stigma is that's what she was focused on the other day. It's just 2 days ago she told me about this. She felt that stigma because she thought, well, I exercise, I eat well, so how come this has happened to me? And so even she's not a member of a minority population, felt that stigma too. Very interesting.
Well, thank you very much, Kathryn. I think it's important, and I talked to my Ron Palermo, who is also a patient partner in Scarborough, and we share the same thoughts, because he is very involved with the local community and the diaspora around the Scarborough area.
Yeah.
And it's put in there, is ingrained in the DNA. That they don't talk about it because people figure that, oh, this person has diabetes. Probably I shouldn't be standing too close to them in case I catch it or something of that. There is the lack of knowledge about diabetes. And that is the huge challenge for researchers like yourselves to sort of try to penetrate the first barrier so that they can, if I could use the word, I call it open up the kimono, that you can see to their heart what they're going through. And I think you'll get a much better response from them directly once you get their confidence. Okay.
Thanks, Frank. That's really helpful. And I think same question for you, Ethel, is your role in the project and your why it's important for you to have been involved. What did we get from that experience of having a healthcare provider inform us?
Sure. Hi, everybody. Good afternoon. My name is Ethel Macatangay, and I'm the Patient Care Director for Nephrology and Chronic Disease Management at Scarborough Health Network. Within my portfolio includes diabetes. So my role in the project since its inception was really to coordinate the needs of carrying out the interventions that were part of the research project and working alongside my diabetes teams to integrate some of the changes in care delivery that aligned better with the rigor of this particular study. It was really important to be involved in this study and my role being to bring forward the potential and opportunities that I saw were feasible with this particular research study, in that it enabled us to integrate learnings and the aspects of change that our patients and our families and our staff actually benefited from. So it was kind of an easy fit, I think, to really support this project, which was a large majority of my role in this project, in that we were already looking to improve and revamp our diabetes program here at Scarborough Health Network. So we already had the resources, the care providers that were providing diabetes, and expertise and knowledge in what was best practice standards and guidelines. As a healthcare system, we always know what it is that we need to do in order to improve care, but the how is always what we kind of sit there scratching our heads about. And so when we reviewed the design of the intent of this research project, it really aligned nicely with the answering our questions as to how we need to ensure best practice standards and guidelines. So my role really involved the marrying up and the liaison between what the project was trying to achieve and how we could actually be proof of concepts or a testing ground for these particular interventions. So to answer your second question there, Kathryn, in terms of like why it was important for us, is that in light of the fact that we were trying to improve the diabetes program and the care delivery for patients in Scarborough who are living with diabetes, it enabled us to have a rigorous approach to the changes that we saw were of benefit to our patients and families. It really helped us to incorporate what the patients were actually saying. So I was really intensely listening to what Frank was saying, and what he said was so true, is that oftentimes as an administrator or a care provider or an administrator of a healthcare program, we often think about our clinical training and what we think is required in order to give care to patients. But when you really listen to what the patients and families actually need and want, much of what Frank was talking about, it usually is a little different than what we as practitioners feel is needed. And so having the patient voice is so important as you redesign or design improvements in healthcare.
Thanks, Ethel. Well, and actually that kind of relates to to where I was going to go next, which was you've made some changes. It has had an impact on older adults with diabetes in the Scarborough Health Network. And some of those changes or some of those impacts that you've seen, could you tell us a bit about those and what changes you've made?
Yeah, so as everybody knows, our healthcare system is changing with the introduction of Ontario Health Teams. The Scarborough Ontario Health Team, and I see Helen Leong, my one of our very good community partners, is on the call here. And one of the things that we did change and what we did learn is how to better integrate services that already exist within our healthcare system. So Care First, who also has a community-based diabetes education center, we really learned how to leverage the care provision that they provide to community patients, but more importantly, how to better leverage the wellness programs that are with her organization, Care First. We also learned of different approaches to care in our other community partners as well, which together in an integrated fashion, we're able to not only create change in our own pathways, which were, now that we think about it, very focused on the acute aspect and care of patients with diabetes. So when their acuity level or their severity of disease reaches a certain level, they often come to hospital. And so we, as a diabetes education program based out of a hospital, oftentimes look after the more sick sort of patients with diabetes. And once we stabilize them, we now have the ability to change our care model so that it better integrates in with our community partners, so that it's a wraparound service where we all have a shared care approach to this patient to ensure that level of wellness is maintained and sustained together as partners. So those were some of the changes that we actually made based on the learnings and based on some of the patient family feedback that we received on how much better that was for them.
Thanks, Ethel. That's really helpful. And if Maureen were here listening to this, she'd be so excited because that was her vision with this intervention. It was always from the start, not the acute side, but that keep things going and looking at prevention and promotion, health promotion, and incorporating that into the intervention so that we could keep patients moving on the right path. It's not so much an acute, but a lifestyle change that's needed. And you're speaking to that and the changes you've made. So Maureen would love to hear that, Ethel. And I guess, Melissa, maybe I'll turn it over to you to continue with some questions.
Great. Thank you, Kathy. It's just been so rewarding to hear both of you share about your involvement in the research, and this has been truly one of the most rewarding research projects I've worked on. I've been so glad that I was brought on to join the team, because I feel like the partnership was kind of a wraparound and a shared care, and as a researcher, a clinical researcher, it just made me feel good about the work we were doing. So I wondered, since we're talking about how to move research into the real practice world, I wondered if you could both reflect on your experiences participating in that last phase of the research, where we thought about how will the community partnership program go on. So maybe Frank, if you could start talking about your reflections on participating in that last phase of the scalability assessment.
Thank you, Melissa. That's a great question. And I was since I wouldn't say since Genesis, when I was involved with the ISAT and all this research, I was pleasantly surprised that they did an extremely thorough work in sort of formulating how the go-forward strategy was going to look like. I didn't declare myself, I'm a professional engineer myself. And I like to see, like Ethel was talking about proof of concept right now. I think they did a lot in the proof of concept, trying to nip all the corners. And then where I see where ISAT is going to move forward to is organically grow the thing right now. It may not be perfect, Melissa, the first time, but we can make the fine tweaks. But now that we've done the proof of concept, we know there's a lot of great things that can be done. If I could have a little segue here, I see the work that Ethel does at SHN and Helen Leung with Care First. There's teamwork they do. I think the thing is coming to fruition, right? Sometimes people are very anxious. Why can't it happen faster? The way I look at it is like watching paint dry. It takes time, right? Or like people that are really aficionados of wine, they say good wine takes its time right now. So we have to be patient. And I think patience is a virtue. And really, if I can go into the segue, the final phase of it is that if I can go back here, Melissa, is that a lot of the people that have diabetes, I'm talking of the people that are in the minority, or probably Kathryn said is the majority also. I really like them to be tuning into the station WII-FM. What's in it for me? They will not turn the knob of the door to let you in if they see that there's zero value that you're going to give them. Especially, you're not going to try to bother me again right now. But if they see value, to be honest, Melissa, I think your prayers are heard. You can put away the rosary beads and you can, things are going to happen, right? I hope I'm not offending anyone of the Christian faith, but those are the things as a lived-in experience, working with people, those are extremely important things. So I think the scalability should proceed. We'll never get a perfect utopia solution, but at least you can tweak it as we move forward. The alternative, doing nothing, is not an option, especially when we put a lot of sweat and tears and equity into this whole process. We should move forward. I'll leave my, I said, I say my piece right now, Melissa.
I agree, Frank, very well said. And when you're talking about engaging other people living with diabetes in this type of a research process, what are some suggestions you have to engage people, to get people involved, and how do we pitch that, what's in it for them, so they'll tune into that channel, as you said?
2 words, Melissa: hard work. Hard work. And to be very honest, you have folks like Helen Leung and Ethel, when they speak to people of the same diaspora, there's usually a lot more acceptance right now, I find, okay? Then because they said, well, this person is living, she can't be telling us a whole bunch of baloney right now. They are concerned about their welfare and care. And that is where Melissa is getting people on the front end to say that, look, I have the same problem. We are trying to fix this thing. If we ever fix, we're all better off. And those are music to the ears, right? When they can see there is something here, is light at the end of the tunnel. I'm not saying you're going to get a cure, and not a freight train coming the other way, right? And it's important that they have that confidence that you're going through this journey with them. And Melissa, that is important. Send a message that this is not just for me as a researcher, it's for you. And I think you'll get a lot more acceptance right now, and people will buy into your whole process. I hope my 2 colleagues here, Ethel and Helen, would agree with what I'm saying, because I know the good work they do. And keep up the good job.
I agree wholeheartedly. This has been about teamwork and partnerships and relationships. So I think I'll turn it over to Ethel to build on what Frank has shared about participating in that last phase, the scalability assessment. What were your experiences with that part of the process?
Yeah, I don't mean to simplify things, but when you hear people like Frank and what it is that he's saying, the answer to the question, what's in it for me? Like I'm a care provider to my father who has kidney disease and is on dialysis because of his diabetes. He developed kidney disease. At the end of the day, what we're trying to do here is truly to make things easier for the patients who live with chronic disease. Full stop. And when I think about what we've learned along the way and the experience that we had as a team here at Scarborough Health Network and participating in the final phase of this study, is that in the phases leading up to where we're at today, things didn't go as well as we wanted them to, partly because of the fact that we were dealing with a pandemic. And, someone like me and probably Frank, who likes structure and who like rigor, it kind of, COVID threw a big wrench in what it was that we were trying to do. And so we really had to pivot and maneuver to enable us to continue at least some of the aspects of care. Like you said, it was supposed to be face-to-face. All of our metrics were set up that way. And at the end of the day, we ended up doing virtual or telephone, and it just wasn't the same. And I think that despite the measured outcomes of the study not being what we had actually hoped for them to be, we learned, I think, the importance of not just quantitative measures, but qualitative measures as well. In speaking to the team and speaking to the patients, the outcomes that we thought might have been captured in what we were measuring didn't actually pan out that way. But it felt like we were doing the right thing based on some of the behaviors we were seeing with our patients and our staff and the families, based on what they were saying to us. So a lot of these qualitative type of measures, I think we could have done better at in terms of using a different lens of demonstrating that what we were doing, the change that we had implemented, was actually making a difference. I also think too that, along the way, we had a lot of learnings that really impacted how it was that we were to change our elements of our program. So I spoke of those a little bit before, but I think those lessons learned can be applied to the delivery of care for any chronic disease. So the partnership, the navigation, the coordination of care, the learning of what actually exists in our region, and bringing those stakeholders together to be able to have them at the table to co-design this care delivery model, right? So, in terms of the last phase of looking at scalability, I think that if we don't seek to scale this up, we miss out on a lot of opportunities of things that we're still scratching our head about. I mean, we talked about the different nuances of care delivery for different patient cohorts. So we know within Scarborough, we have a very diverse, culturally diverse population. And we haven't really scratched the surface around equity, around the barriers to access, language, transportation, all of the determinants of health that I think we still need to explore and to look at. At Scarborough Health Network, we're looking to build a community hub called the Bridletown Neighborhood Center. Its vision is to be a center of excellence for chronic disease prevention management. And it's meant to be a first of its kind, in that we are going to have not just acute care in this building, but we will also house our community partners. So you have a model now where you've got a community hub that is a one-stop shop for access to service for patients, and a further opportunity to take a look at how we utilize these proof of concepts of how we enable that navigation, that coordination, that health equity in almost like a bit of a petri dish within the Bridletown Neighborhood Center, but scaling that out into other regions of Scarborough, where outside of the region where Bridletown actually is to be built. So lots of opportunity, which I see this research project could really help to support and to provide rigor to around the analysis and the assessment.
Well, we're with you. We're with you, Ethel. We'll line up those Petri dishes. Thank you for your comments. We wanted to open it up now so that the participants could ask questions of Frank and Ethel and Kathy and I, should you wish.
Yeah, and Melissa, I'm just going to say there just was a comment there from Tom. Hi, Tom. Who said he was at the other end of the spectrum of Frank, and we can see his comment there, right, Tom, in terms of impatience versus patience. So an interesting comment, Tom. I don't know if you want to ask a question or make your point by unmuting.
Well, thank you. I hadn't thought to address it live, so I'll improvise. Really, in terms of the diabetic foot, which is just a small aspect of the overall diabetic care, it's so underappreciated of all the complications of diabetes. It takes the most cost, it takes the most money out of the care system. And the ability to do better, considerably better, requires no more than coordination of the aspects we already have at hand. The commentary I'd written some years ago, I called "Some Assembly Required," because that's how I saw it. That's what we need. We have all the bits. We don't need any new technology, anything different. That's where my impatience comes from. I know we can do better tomorrow, if only ... Oh,
the ... dots again. Yes, thank you. And you saw some vigorous head nodding from one of our partners on the line. So yeah, people are listening, Tom, which is great. And some messages coming up in the chat. Helen has kindly put up her Zoom hand. So please, Helen.
Yeah, I truly want to thank the McMaster University doing this research, and really thankfully really have involved the users in really providing evaluation and speak, because I think Frank has pointed it out. It's most important is that the value. What's the value? And what's in there for me? And it's really because the whole program, the whole design is really the patients and their caregivers have to have the 100% buy-in. If they don't buy in, and if we don't, as Ethel said, that make things easy for them, because basically it's that they are going to really to buy in the concept, to buy in the practice, and then they do it. And when they do it, it has to be easy for them, and then the resources are easily accessible for them. So if it's at that, well, say like the evaluation last time said, well, moving it from hospital-based into the community-based. So moving the community-based, how are we going to make it really accessible? And I think the research already pointed to us, because when we want to replicate things, scale things up recently, last week we had another symposium talking about the lessons learned from the COVID, the high priority communities program. People identify and ask about what are the secret sauces? What are the secret sauces in doing things to scale it up, to spread, to address population health, to improve population or health equity? So this is exactly the purpose of, say, like, I think it's the research, the rationale behind as well. So that we would like to improve population health. We would like to, say, like, make the programs more accessible and equitable. And then what are the secret sources? The research already, identify a few. And then Frank and Ethel, talk about what are some of the available, platforms that will be able to scale it up. And just this morning, Ethel and I, we just participated in one of the Scarborough, the Ontario Health Teams. Because Ontario Health Teams, they are basically given them almost like every Ontario Health Teams are asked, well, priority, develop your clinical, chronic disease management care pathways. And this is exactly the platform that we can leverage on. And then Ethel also talked about, for instance, like there is the investment of developing that, say, like care hub. So basically, these are the different platforms that we'll be able to leverage on those platforms to roll things out. And as Frank said, that, well, we have to really emphasize on what's in there for me, the value to the patients and their caregivers. So in order to make it, say, like the very first, if we are able to have that buy-in, I think we are halfway success.
Helen,
then, yep.
And thank you. Like the secret sauce shouldn't be a secret, right? So let's take the secret out of the sauce. Yeah.
So that's exactly, academics and making all this really in the public domain, that not just, make a secret to ourselves, but we would like to contribute to the healthcare system. I don't want to talk too much, but I think there are lots of comments already made, and then to put it into really practice, say that, because it's not that we don't know the how to, but it's the determination to have the collaborating partners, to really the willingness to work together, because all boils down is the determination that is to just do it. And then, do it, measure it, scale it up continuously. It's a journey, as Frank and Ethel talk about. This is a journey.
Helen,
just do it. Yeah.
And Helen, I'm really glad, and Dr. Kathryn Whiteside is here. For those of you who don't know, she's made a comment. So we're fortunate. She's from Diabetes Action Canada, and so we pay close attention to Dr. Kathryn Whiteside and the points she makes, and certainly with our partners who are part of our network. And we've submitted together with Diabetes Action Canada, the collaborative has submitted. Yes, it's academia, but nonetheless, it's another way to share what we're doing around. You're not surprised to hear that a lot of people with diabetes are aging and aging well and living well with many conditions, and that's important too. And Tim has raised his Zoom hand. I'm just keeping an eye on the time. I have to play the bad. This would put me, I'm a bad person. So Tim, your comment, just I'm keeping an eye because we're going to want to move to that collaborative conversation portion. But as we say with these conversations, we're just getting the conversation started, right? Because you can't in these hours finish the conversation. But Tim, please go ahead. And you have to unmute first. And Tim has not unmuted. Tim, we still can't hear you. Okay, that was the awkward Zoom pause right now. Is there any other points? Yes, and Melissa is kindly responding there in the chat with lots of exclamation marks, of course. That's good. So what's going to happen now is I'm going to pass it over to Mike and Tina, and sometimes they step in, and Tim, of course, we look forward to your comments if we're not able to do that. But there's more time, just as Sue is saying, for questions and sharing and reflecting together. Thanks, Tim, and others. So we can continue the conversation. I know some people have to go, and that's okay. You can reach out to us at any time. Just get us on the website there, and you'll find out our email address and all those good things through you received the invitation. Allison's also going to follow up with some follow-up to you. So thank you very much for joining us. And without further ado, I'll turn it over to Tina or Mike, who's going to take the Zoom microphone.